today. So we have Jerrod Anzalone. He'll be presenting the rural health domain team perspective. And then we have Tim Berquist, who's going to be talking about the N3C Community Notes. You guys are familiar with the key stats, 56 sites. The data is released in our enclave, and 219 sites that have DUAs executed. And there's a link for our public dashboard that we'll put in the chat, and everybody should have access to it and should be able to see it. That's just our high-level stats from there. I'm going to turn it over to Jerrod Anzalone, who's going to be discussing his work as part of the rural health domain team. All right, Jerrod, I'm going to stop sharing and you can share your screen.
All right. Can you see my slides okay?
Yes.
Not the presenter view? Okay, great. Yeah, thanks for having us. Yeah, really excited to talk about this. I'm not the only one here from the Rural Health Domain Team. We also have Dr. Porterfield from the University of Kentucky. He's an infectious disease doc, and he does a lot of things. So I'll let him introduce himself. My name is Jerrod Anzalone. As I said, I'm with the Rural Health Domain Team. I work in informatics at the University of Nebraska Medical Center, and I'm also a PhD student in biomedical informatics. I will be discussing opportunities to study rural populations in N3C, including some of our preliminary findings, and Dr. Porterfield will be discussing an ordinal scale we've been developing for a few months that can be used to measure point-in-time disease severity. So along with Dr. Beasley, Dr. Hillegas, and Kim Murray, I help to organize and lead the Rural Health Domain Team. We meet bi-weekly on Friday afternoons. Our next meeting is actually this Friday. As background, the Rural Health Domain Team was born out of the IDEA CTR Network's foray into N3C. The Institutional Development Award, or IDEA program, is an NIGMS administered program that funds a network of clinical and translational research centers, or IDEA CTRs, that function similarly to the NCATS funded CTSAs. Among the 11 IDEA CTRs, 8 of us listed here joined N3C in summer 2020. IDEA CTRs serve many underrepresented groups, including a large contingency of rural America. So we have a vested interest in studying rural needs. This map shows our primary catchment area, which reflects our strong rural focus. While the Rural Health Domain Team was initiated by the IDEA CTR community, we are open to all comers. Our mission is to understand the epidemiology, utilization, treatment, and outcomes of the COVID-19 pandemic in rural communities. These communities are among the most underserved and resource-scarce populations in the US, yet there have been limited data on COVID-19 mortality in rural America in the literature. We believe N3C represents a unique opportunity to gain a greater understanding of the risks faced by rural dwellers. I was fortunate enough to have been involved in the immunosuppressed compromised domain team. So our organizational structure is very similar to the one deployed by Dr. Rosalind Mannon and Amy Olex. The ultimate goal of this organizing structure is to share resources, expertise, and enable team science to produce impactful results at scale. There are various roles defined within this context, including subject matter experts, data liaisons, informaticians and logic liaisons, biostatisticians and epidemiologists, and then a new role that we're hoping to integrate within our pipeline, which is the dissemination and implementation liaison, who will work to translate N3C results into evidence-based practices, interventions, and policies in the real world. I think the beauty of this format is that it enables researchers to share their expertise while not requiring them to master an end-to-end process. We all have our strengths, and this format acknowledges that. The Rural Health Domain Team operates collaboratively within the entire N3C ecosystem and benefits from the tremendous support provided by Drs. Gersing, Shute, and Handel, as well as the entire N3C team. It takes a village to make something this big successful. We have subgroups that focus on specific issues, including outcomes, treatments, access to and utilization of care, and substance abuse. We are very open to suggestion for future direction and additional project ideas. So there are numerous ways to categorize rurality, but the literature predominantly relies on either rural-urban continuum codes, RUC, or rural-urban commuting area codes, or RUCA. Both of these standards are maintained by the USDA Economic Research Service. I will be primarily focusing on RUCA codes here today. They utilize either census tract or zip code and are based on standards maintained by the Bureau of Census, Urbanized Area, and Urban Cluster definitions. To study rural populations in N3C, you need to have some sort of a geolocator. We use zip code here. Zip code or county is available in the level 3 data set. Since county reporting in N3C is very sparse, our analyses have relied on zip codes thus far. As of the most recent release, 39 of 56 data partners reliably report zip codes for their patients, representing approximately 2/3 of the COVID positive population. N3C has external data sets for RUCA and HUD zip county crosswalk files that the SDOH team put together. They are in the knowledge store. To use this data, there is some data cleaning involved. Some sites appear to be providing 5-digit zip codes, but they're really restricting to 3 digits and then putting trailing zeros to fill out 5 digits. However, compared to the other harmonization required in N3C, this is reasonably straightforward. After cleaning the data a bit, you can link to the data sets for RUCA in the knowledge store. We use this to create a master location table that includes RUCA, RUC, and some other social determinants of health indices. RUCA codes include 10 primary and 21 secondary codes, which are usually clustered in analyses. They're a very flexible way of studying rurality and commuting patterns in general. For our purposes, we used a classification scheme that's pretty well established in the literature to determine broad access to care along rural lines. We classified N3C patients based on the degree of rurality into 3 groups. The first is primary RUCA codes 1 through 3, and they represent the urban populations. The second is primary RUCA codes 4, 5, and 6, and 4, 5, 7, and 8, and they represent urban adjacent rural areas or those that have high commuting flow. And then the final 3, 6, 9, and 10 represent non-urban adjacent rural communities or those with very limited flow into a nearby urban center. So prior to doing any research on rural populations, we sought to determine whether N3C is reasonably representative of the US population. A starting point is just to look at the distribution of patients by zip code centroid in N3C. You can see here there are big swaths of the country where there is no zip code information in N3C, and this is a limitation that needs to be carefully handled. So this is the US population density from the 2010 census. Non-metropolitan areas constitute, the majority of the US area, yet represent under 20% of the total population. And if we go ahead and map over where our N3C population is on this map, we see a lot of overlap with the sites reporting zip code data in N3C with the big population centers. We have a large contingency on the East Coast and the Pacific Northwest, as well as along I-80, which is where you'll find me. But we have a high degree of missing data in the Southwest and Texas. While the maps themselves show that there are opportunities to expand N3C into parts of the country that are currently not represented, we found that N3C has a very similar distribution along rural lines as the country. We compared our results in N3C as of March 31st, 2021, with the public health reporting done through Johns Hopkins, and found similar distribution along rural categories. We see a nearly linear progression in terms of case fatality as the population becomes more rural. Here we showed the Johns Hopkins data through the same time period and find that, we have a very similar nearly linear progression. Yet despite these findings and the fact that this is mostly public data, there have been very few studies to date reporting on these discrepancies. This will likely continue to exist as vaccination rates have been lower in rural areas than their urban counterparts. And so that gets us to our first broad study that attempts to answer the fundamental question, do rural and urban patients have similar outcomes with and without adjustments in the N3C COVID-19 community? Our plan involved a lot of data exploration and testing potential covariates. We started with 2.1 million N3C patients that were COVID positive. We looked at that entire population to determine a correlation with hospitalization and the risk associated with death or hospice in the hospitalized population. So here we show a very typical cohort selection process where we define our variables of interest and develop a computable phenotype for our cohort. However, we differ a bit from some of the other published reports we've seen to date in that we are very systematically restricting the data partners we include in our study based on data partner robustness. So these determine minimum reporting requirements that determine whether we include a site in our study. I come from a PCORNet shop, so this is similar to the data quality or robustness checks required for inclusion in their study. We found this method to be preferable to dropping patients with missing data, as that can produce unintentional bias. For our study, we included temporality in terms of diagnosis. So we only included sites who restricted dates by 30 days or fewer, so we could include quarter of diagnosis in a covariate. We also found that many sites were not reporting a high degree of deaths, with a few sites reporting almost none, so we excluded those sites as well, if they were one standard deviation below mean reporting. And then finally, we did the same with BMI, which we included as a covariate in our model, our final models. So at a high level, this ended up dropping our data partners from 55 down to 27. We included only those sites contributing zip codes, then excluded those who shifted dates and had either limited death or BMI reporting. So this had the unintended benefit of creating a cohort with more robust information across all domains, including greater prior visit history, decreased BMI missingness, and higher medication reporting. This process is available as a template in the knowledge store. So if you're interested in using a similar approach in your studies, you can look at this. It takes a while to run, but it's very helpful to start digging into the data that's available at the site level. You can actually filter it down by a specific study cohort or run a specific concept against it, so it's pretty flexible. In terms of our results, I'm going to focus on the hospitalized cohort here. We found that rural patients were impacted later in the pandemic, with more diagnoses coming late in 2020. We found they had similar therapeutics interventions, but were more likely to require oxygen support or mechanical ventilation. We also found that they had higher BMI and were, on the whole, a lot older than the urban population, which is similar to what we would see in the literature. Finally, we found that in pretty much every comorbidity category we looked at, the rural populations had higher incidence directly along rural lines, including cancer, renal disease, hypertension. They also had higher incidence of tobacco usage. So again, looking at our hospitalized survival curves, we found this is the urban line. It's kind of hard to see here. These are the rural groups. We found that survival over 30 days from admission, you're at a significantly increased risk if you're coming from a rural area. Interestingly, we ran the same analysis with the same data partners in the uninfected cohort and found that, you know, it's severely attenuated in the negative group, but you see a similar discrepancy in rural urban outcomes. And then our final mixed effects logistic model included fixed effects for gender, race, ethnicity, BMI, age at visit start, our Charleston comorbidity composite score, and rural category, with an outcome of hospitalization in the full cohort and death or transfer to hospice in the hospitalized cohort. After conducting a lot of analyses to clarify the final models, what we're calling rural versus urban effect, we ended up running the models at the site level to determine the overall variance across sites, and we ended up adding in a data partner as a random effect, which produced much more favorable residuals in the final model. In both cases, the odds for hospitalization in the full cohort and death or hospice in the hospitalized cohort were much higher in the rural groups. Even after adjustments, these patients have a higher odds ratio of being hospitalized, dying in the hospital, or being transferred to hospice. So now I'm just going to pose some lingering questions that we've had before I hand it off to Zach. We don't claim to have all or even most of the answers, but we are working on a methods paper to hopefully dig into some of these questions. First, we hope to understand whether we are reflecting a true rural-urban difference, or if the nature of N3C, which primarily is built up of tertiary care centers, is creating a false impression because we are seeing referrals who are sicker at admission. We ran our models in the COVID-19 negative comparison group and found similar levels of disparity in outcomes along rural lines. So is this a COVID problem, or is this more of a rural problem? And then finally, we hope to understand how this data can be used to study additional topics related to COVID and rurality, including past vaccination and breakthrough cases, and long-term mitigation strategies and how they influence outcomes. So with that, I will hand it off to Zach. Maybe.
Thanks, Jerrod. Can everyone hear me okay? Let's see. All right. Jerrod, does that look all right? You're seeing the screen okay?
Yes.
Presenter mode, is it all right? Okay, good. So I appreciate the opportunity to present. My name is Zach Porterfield. I'm an assistant professor at University of Kentucky. I'm a PhD trained virologist, primarily appointed in microimmuno, but I'm also a clinician and appointed in the Division of Infectious Diseases. I run several of our COVID-19 clinical trials here at the University of Kentucky. And we're going to talk about adapting an ordinal clinical scale for use with real world data today. And I'm, of course, speaking on behalf of a number of incredibly hardworking, brilliant people. Oh, this is speaker view. Let me see if I can change that quickly. All right.
That looks good.
Is that better? Okay, perfect. So, certainly this is, I've been on board as a bit of a clinical advisor for this project and invested in the development of it. But, certainly a lot of credit goes to the rest of the team in terms of the nuts and bolts of what we'll present today. Moving forward, the big question is, how can you leverage real world data and the N3C to identify effective treatments for COVID-19? And so we start to think about this. I've borrowed some slides. This is sort of a nice one about thinking about general treatment categories. And we've been through more than a year and a half of the pandemic at this point and seen a lot of potential therapies come and go. In general, we think about repurposed drugs where we're taking things that already have a good phase 1, phase 2, phase 3 safety profile and seeing if they have any effect on COVID-19. In this figure, it's Ebola drugs, HIV drugs, and malaria drugs. This was relatively early. But we're also thinking about overall endpoints, and things like anticoagulants may be part of that story. Certainly antibodies, and some of these are bioengineered or convalescent serum from recovered patients, and then certainly the COVID vaccine. So if we think about, in general, we're probably focusing more on a repurposed drug standpoint, but trying to say, what are the potential therapies that may have an effect, and how can we leverage the N3C database to understand things that may have been missed? As you're developing a clinical trial, there's a lot of difficulty in terms of choosing the right patient population or inclusion exclusion criteria and endpoints, and you can actually miss signal that may be present. So some of these medications may have a signal in a certain patient population, but it hasn't been tested. So thinking about real world data and big data as these medications have been used to see if there's maybe some therapies that we've missed. It's a early sort of mid last year slide that came out that I still think is quite reasonable in terms of understanding COVID-19 is the differences in the spectrum of illness and the phases of illness. So in general, we often have a viral response phase early in illness and then a host inflammatory response phase later on, where there really are big changes in terms of what's happening in the patient and the kinds of treatments that might be beneficial. So early on, high levels of virus, maybe a flu-like syndrome or a viral prodrome, versus later in the illness, some patients progress to a circumstance where the virus may actually be low, non-detectable, or gone. And what you have is a host inflammatory response that's, hyperinflammation, and really the cytokine or hyperinflammatory phase of the illness is driving the severe illness. And there may very well be different phases and different treatments, for these different phases. This has now been expanded and in fact continues to be expanded where, there's an early viral phase, a cytokine or hyperinflammatory phase, a hypercoagulable phase, a late hyperinflammatory phase, and then sort of a long COVID or post-acute COVID syndrome phase that's still being described. And actually these phases are being described, but we do see patients moving through each of them. And it's relatively easy to understand or to conceive that a certain therapy might be very beneficial in one part of the illness, but less beneficial in others. As we start thinking about developing clinical trials, which is something I've spent the last year and a half working on, there are a number of different potential endpoints that can be considered as your primary or secondary endpoint. Mortality, length of hospital stay, time to clinical improvement, decrease in the cycle threshold of the nasal swabs that you're obtaining, lungs injury score. And despite the fact there's multiple potential endpoints, some of them really are only useful in certain circumstances. So mortality may be very low in an outpatient group with no comorbidities. Length of hospital stay only works if you're in the hospital. ICU outcomes, things like PaO2, FiO2 really are only in our ICU-based population. So thinking about, what is something that we could really query the N3C database and would be a robust endpoint across the clinical spectrum. If we think about key transition points, and so this is a figure that we put together, where in this first green circle, we have all of our outpatients with COVID-19. In the second one, we have all of our hospitalized but non-critically ill inpatients. And we're really thinking about a couple of transition points. If we can keep people from coming to the emergency room in the hospital, that's improving, three very key outcomes, one of which is the patient outcome. The second is a transmission risk. If people aren't coming to the ER and coming to the hospital, they aren't increasing their risk of transmitting the virus. And also, decreasing health expenditure and use of limited resources. So, as a frontline provider, there were times where there were glove shortages and PPE shortages. And these are realities that we have to consider as we think about, therapies that might prevent that transition. So giving something to an outpatient that would prevent them from making this transition to a hospitalized circumstance. And also our non-critically ill inpatients, thinking about things that keep them out of the ICU and off of a ventilator, which again, improve patient outcomes, decrease transmission risk, and decrease the health expenditure and use of limited resources. If you look at it the other direction, are there therapies that get people out of the ICU, get people out of the hospital and back home? And so, these are major transition points, but we really are interested in what happens across this entire spectrum. One interesting approach to this is the use of an ordinal scale. So if mortality is your only outcome or your primary outcome, it misses a lot of that nuance of those transitions. Whereas an ordinal scale, is not unique to COVID. This is something that's been used in numerous different disease processes and is a Likert type scale where you assign a score to various different conditions and health conditions. And this, I think has been adapted quite well in clinical trials. And we're really looking at how do you adapt it further to make it available for N3C database querying. So in general, the WHO R&D blueprint, which came out February 2020, so quite early in the pandemic, identified 4 ordinal scale states, the 0 being uninfected, 8 being death, and in between, really looking at some easily identifiable things that really correlate quite well and in a very sensible way with patient outcome. So if you're ambulatory, you're a 1 or a 2 if you're at home. If you have no limitations in your activities, that's a 1. If you have limitations in your activity, it's a 2. Then you're in the hospital but not on oxygen, then in the hospital on oxygen, then you have more invasive oxygen, high flow and non-invasive ventilation. 6 being intubation, mechanical ventilation, and then ventilation plus additional support. So things like dialysis or pressors or ECMO. Being extracorporeal membrane oxygenation. So the nice thing about this ordinal scale is that it's very sensible in terms of needing oxygen is a very logical step in terms of patient worsening. It also tracks very well with things like health expenditure and use of limited resources, ventilation being another good example, and things advanced care modalities like pressors, RRT, and ECMO being additional examples of that. So the nice thing about the ordinal scale, again, is it correlates relatively well with this transition from a viral response phase to a host inflammatory response phase and beyond. We might think that patients who are early in the disease process might be at a lower ordinal scale, so they haven't had time to transition over to being more ill, versus if you are more ill, it tends to be later in that phase. And this has been adapted. So this is a recent editorial looking at one of our monoclonal antibody treatments for COVID-19 pneumonia, and they've adapted an ordinal scale, and they're looking at various medications. If we step back to this treatment very quickly, if we're in the viral response phase of illness, you might want a direct acting antiviral treatment versus later in host inflammatory phase, you might want an anti-inflammatory like a steroid. Steroids might be very bad in the viral response phase when you want a robust immune response to the virus, but would be very good in the host inflammatory phase. And by comparison, something that is directly antiviral would make a lot of sense early in infection and perhaps lower on the ordinal scale than later in disease, where maybe the virus is actually not present in large amounts and the disease process is largely being driven by inflammation. So I think that nuance of understanding patients' transition through various health states is really important. And so this is suggesting that early in an ordinal scale, something like remdesivir, which is directly antiviral, may make more sense versus late in a disease state, something like dexamethasone. In fact, the recommendations have been, giving steroids, dexamethasone being an example, when a patient needs oxygen, and that shifts that towards that hyperinflammatory phase, and just showing that certain new drug targets can be dialed into that ordinal scale. So we sought to modify the ordinal scale because certain things are actually quite difficult to identify in large real-world databases. And so things like limitation of activities being the difference between 1 and 2 is really tricky to identify in a bulk data set. It's something very easy to ask a patient. So when you're running a clinical trial, you'll say, are you up and around? Are you cooking dinner? Do you feel like you can do your normal activities? It's very hard to query that in an outpatient record or in a bulk database. And so we've made some changes or suggested changes to the ordinal scale to allow for the data that we have to really assign an ordinal scale designation for each of the patients that we have. So we've collapsed 1 and 2 down into 1. Again, the numbers here don't matter quite as much. This is a Likert type scale as opposed to a proper, the values may mean less. It's really the differentiations that are important. 2nd being a hospitalized patient, not on oxygen, 5 being oxygen, 7 being mechanical ventilation, 9 being organ support, and 11 being death. And again, these were categories where we felt that we had the ability to assign the status of the patients relatively well. So, mechanical ventilation comes with procedure codes that were relatively robust. Oxygen is a little bit tricky, and so identifying, how much oxygen was, turns out to be a bit of a difficulty. And clinically, we know this is, notoriously difficult. Looking at the chart to see what oxygen people are on. If you look at the order, there's almost always an order for oxygen. If you look at what is charted, it doesn't often mimic exactly what the patient is getting. And so we have assigned an oxygen middle ground of 5 and felt that we were able to differentiate patients who are hospitalized, not on oxygen, and those on mechanical ventilation and this middle ground of oxygen relatively well. Thinking through concept codes, and there have been a number of different challenges because now the idea is we want to query different therapies and assign ordinal scale changes and follow patients through an ordinal scale to see if they improve and see if there's an effect based on anything that they were given. And there are some very straightforward designations. So something like azithromycin, not a lot of difference there in terms of all of these are therapeutics that are being given for a therapeutic indication, versus something like heparin on the surface seems relatively easy to categorize, and in practice has been very, very difficult. If you have something that's at 5,000 units and it's an injectable solution, that's almost certainly a therapeutic indication. If it's at 2 units per mil, it's hard to imagine that you could give enough mils to get anything that would have a systemic effect. And so we spent quite a bit of time looking through the many, many hundreds of different codes for heparin to try and think of the best way to categorize these concept codes and put them into categories that were able to then track the changes in ordinal scale over time. Some of the successes we've had. So this is pulling directly from the N3C database and assigning an ordinal scale across weeks 1, 2, 3, and 4 of a patient's hospital stay, where we're defining diagnosis or testing as the initial 0 point, and then looking at week 1, 2, 3, and 4. What's nice about this is that this does mimic the breakdowns of some very large public available databases from CDC and other sites, that we are recapitulating the normal distribution that we would expect and the transition over a period of time with, as people tend to recover. So looking at this visually, we have week 1, 2, 3, and 4, and the number of patients who are in ordinal scale 1, 3, 5, 7, 9, and 11. And so we see early on in week 1 versus week 4, I'm sorry, the purple should be orange there. We see people are getting better. For the most part, a majority, more and more patients are being found in that ordinal scale 1 outpatient category. We also see a transition to patients who are passing away over the course of 4 weeks, which mimics the sort of tumultuous path that occurs over the course of usually a couple of weeks, and also the fact that there is no back transition from ordinal scale 11 to 9. And so we're starting to recapitulate these normal differences that are expected. We're also looking at targeted therapy and looking at changes and really working and optimizing the granularity with which we're looking at the data. So, thinking through changes over the course of weeks versus is it better to look at daily changes to assign, a value to the use of any particular therapy. So having an antiviral, as a clinician, I think of an antiviral effect usually at day 4 or 5 is where I'd start to see some improvement. Similarly for antibiotics. And that, maybe 1 week is a bit too granular, but we're certainly seeing some success in terms of designating patients across the spectrum. We do have some really exciting data that we're hoping to share relatively soon, but in terms of what we've achieved thus far in future directions, certainly we've navigated some of the challenges in terms of taking something which clinically is very easy to use for a clinical trial, where you can ask the patient all of these questions and put them in the right ordinal scale category. When we're looking at real world data and we don't have the ability to follow up on the individual patient level, we've navigated a lot of the concept codes and the stratifications and adaptations of the ordinal scale so that we can do this with good success and predict those breakdowns in ways that I think are powerful. Future directions, adapting this and finding the right granularity with which to examine the N3C database to try and pull out different therapeutics really is where we're headed. And I think we're, on the precipice of really running some of those programs and pulling out some answers. The hope being, again, are there things that we've missed? So if something, in early clinical trials, most of the trial therapeutics were being given to the very sickest patients who were in that hyperinflammatory phase. We did that sort of out of desperation, that we were looking for something to help those patients. But, a direct acting antiviral therapy probably has a better effect early on in disease. And, a therapy that helps somebody in the ICU is incredibly important, but also something like a Tamiflu that we could give to an outpatient and prevent them from coming into the hospital also has incredible value. Things that might decrease transmission, decrease hospitalization, improve patient outcomes. So with that, and my thanks to Jerrod, our thanks, and I'm happy to take any questions if there's any time.
Zach, thank you so much. Following the chat over here, so I think Jerrod was answering some of the questions. Harold Lehman just asked a question: will this work be presented on a state transition diagram?
So certainly, there are a number of ways to visualize this data, and so we're looking at the best ways to really identify those processes. But looking at what happens when a certain therapy is given over a period of time, I think state transitions is one powerful way to potentially do that. So yes, in short, the answer is yes.
So I have a more general question. So first of all, absolutely beautiful work, both of you. It's really exciting to see how much work has been done. I was really intrigued by Jerrod's questions at the end and had been thinking similar things for quite some time and have been working to try to get, figure out how do we get more clinical organizations involved in N3C so that we're not only selecting for patients that are being referred. And so it's a huge issue in really understanding. And we, the problem is, of course, that many of those organizations don't have a common data model. So even if they wanted to participate, it's not so easy to help them do so. Some of the, health information exchanges or some of the organizations like OCHIN have really been able to help do that for some areas, but we still have huge gaps. And I'm just wondering if, this is not an analytical question, it's a strategic question, but maybe we could work within the context of the rural healthcare domain team to really come up with a strategy to engage organizations as well as a technology solution to help get that kind of participation. Because I do think if we're, and this isn't just specific to COVID, but if we really want to understand the health disparities in these communities, we're definitely looking through a lens that is not giving us the full picture. So I don't know if you have any ideas or want to speak to that problem.
Yeah, I think it's very individual how sites are going to respond to that. I don't know holistically how we can get these sites to engage independently with these national efforts. I don't think that's likely. In Nebraska, we're attempting to build relationships. If you're Epic, you're familiar with the Community Connect platform, and we're trying to build relationships with those rural hospitals that engage with us on our Community Connect. So we would have a bigger catchment area in our rural partners. But that's still an incomplete solution. That's what we're doing. Don't have suggestions for the country as a whole.
I think I would follow up on that. There are some opportunities. NIH has put out some larger collaborative grants to try and pull people together to tackle things like post-acute COVID syndrome and define it. And one of the approaches that we've taken, born out of West Virginia, is large collaborations from coast to coast representing rural health. But I think those larger networks that are very inclusive make a lot of sense. But again, a difficult problem, but certainly representing all the voices, in various places in the United States makes a lot of sense. And I don't know how to do it.
Well, let's definitely follow up on that, because I feel like we're mature enough now that we have the capacity to actually do something better than we have to date. And it's not like we haven't tried, but I think some creative minds might get us a little further along the road. I also would invite you to participate in some of the long COVID work that's going on. I think there's a lot of interest in understanding the intersection between the classification strategies that we've created for long COVID and the rural health and health disparity question. So.
Thank you. We'd love to.
Thank you very much. Definitely.
Thanks, everyone. So now I'm going to turn it over to Tim Berquist. I know we only have 19 minutes left. Tim, I hope we're able to do justice to your presentation.
I can get through it. So, my name is Tim Berquist. I'm an informaticist at Sage Bionetworks, and I've been working on this project here for a little bit. So I'm going to talk about the N3C Community Notes, which is a new tool that's going to be made available to the N3C community to help gather lessons learned, institutional knowledge, and just little notes that are kind of getting lost into in the realm of N3C. Yeah, so early on, I think about 6 or 7 months ago, we kind of noticed that there was a lot of institutional knowledge that was circulating the N3C community that really had no central place to be deposited or found. I would sit on all these different calls about people talking about all these little, either methods they've developed, and then another call, someone would ask, how do we solve this problem that someone's already solved, at a month earlier in the course of the research, but there was no place to put all these pieces of information. So we wanted to build a repository to collect this information. So then basically we wanted to answer, how do newcomers find this new institutional knowledge, and how do the experienced N3C researchers then also distribute this knowledge or this information as they develop it. So I've been working on developing this repository called the N3C Community Notes in collaboration with Amin at Palantir and some of the data liaisons and logic liaisons. And it's meant to serve as a community-driven repository where N3C researchers can deposit any institutional knowledge as either a note or a frequently asked question or a little code snippet as an illustration. And so this is what the current dashboard looks like. This is what you would look like. This is what you would see if you were to when you first enter onto the web page. There will be links on the homepage to this. Hopefully they'll be up pretty soon. Yeah, I can also share a link to this in the chat if people want to start looking through it now. Hopefully the links will be made available on the homepage soon. So as a basic user, what you're looking at here is just a collection of notes and little articles that people with the knowledge have written. So this one was written by Katie Bradwell about how, have measurement units in the OMOP measurement table been harmonized this is a frequently asked question. And then she's written a little blurb here. And each of these notes has associated with them tags. So this one would be data exploration, data harmonization, and data quality. You can see there's other metadata associated with this. So note authors, the data was created. And so right now we have a little over, I would say, a dozen or 2 dozen notes that have been written. I have a list of other notes that I have to write. So this will continue to grow. So as this continues to grow, obviously we're going to need filtering mechanisms. So you can search by keyword. And that will, filter down everything to your keywords. So if you're interested in COVID vaccinations, this was a lovely email written by Kristen Koska that I then translated into a note about the caveats and of using vaccine data within sort of real world data repositories and then associated tags. The other way you can filter these down is by type. So we have 4 types technically, but only 3 are currently in use. So we have articles, code documentation, and frequently asked questions. An example of something like a code documentation would be this simple note I created as an example. But when you create a code documentation, and I'll get in a little bit, I'll talk a little bit about how you create these. It'll be a little blurb describing what the code is doing, and then it will render the script as marked down here as just an example. And then of course the tags. The other way you can filter these down is by author. That's pretty self-explanatory. A lot of the tools in N3C in the enclave can do this. And then we can also search by tag. So if you're really only interested in the topic of data quality, you can search by tag, and you can get all the data quality associated tags and notes associated with that tag. And then you can read through them as they're added. So that is it's a pretty straightforward dashboard. If you're interested, we have a lot of tags that are available for use. If you're interested, you can go up here to the tags tab, and you can look through all the different tags that we have available. Each of these tags are under a certain category. So you can look at just like the domain tags. I tried to add all the different domain teams. I know I missed some. So if you're part of a domain team and you come to this tab and you see you're missing, go ahead and add your domain team as a tag. You can do clinical data. I've added all the main OMOP clinical tables so that as we create notes around certain tables, we can then add those tags, etc. So this is free to explore. So if you want to go beyond just scrolling through these and you actually get to the point where you want to create your own note, you would just come up here to the note options and you could create an N3C community note. This little slide will open up and we have 4 different options. If you're in doubt and don't know exactly what your note category falls under, just create an article. It'll cover all your basic note use cases. We also have code snippets. So if you were just to say create article, you'll have this pop up, you'll fill in your title. You'll be able to flesh out the body here. The cool thing is the notes will render Markdown. So if you want to add a link, but don't want to have a really, really long link, you can do the little brackets with around the text and then parentheses for your link, and that'll add it in as a hyperlink to the note, to the text that you're interested in, things like that. You can also do triple, I forget what the term is, but the triple back semicolon, or not semicolon, the triple back quote to add in blocks of code. There's a lot of resources online about how to write Markdown. So just know that any Markdown you put in this body will be rendered as Markdown in the note. You'll then add in tags that are associated with whatever note you created. Obviously there's a lot here, so you'll have to search through. The other thing is you can link knowledge objects or concept sets, training modules, and research projects to a note that will be associated with that note. And I'll show you how that renders. So once you create that, you would add that. The only difference between that and create a code snippet is that there's a block here for adding your code. Whatever code you add in here, all the spaces and enters and tabs and everything will be maintained in the format, and then it'll get rendered inside of a code block, like I showed earlier with with my little code example. And then a frequently asked question, it's the same thing as the article, except we just ask that you frame the title as a question. The reason I'm putting these as two different buttons is down the line when we get a lot more, hopefully we get a lot more notes, I'd like to be able to create a separate frequently asked questions page and just have that constantly updated with new frequently asked questions. So it's really just sort of a categorization difference. So then, you've created your note, you've been able to link things to this note. So just to give you an idea of how this looks, this is the main overview, but, this note here that I created based on Tanner Zhang's, I think it was a Slack message that I used. We've linked knowledge objects. So you'd click up here and this would show up as what knowledge objects are linked to this specific note. In other places, we have training modules. So Sean has created one here about Enclave organization, and he's linked in these training modules to this individual note. And so this note just describes this module here. So that's the quick rundown of what this community repository is looking like. Just to kind of continue on with the presentation. So I guess one question would be what topics are allowed. At the moment, we're not limiting to any topics. So if there's like a trick that you found using the code workbook, feel free to make that a note. If there's something you learned that you think is obvious to most people, but you still think would be useful to some newcomers, that could be a note. Any application tricks inside of the Enclave, domain team specific notes. If I think there's been a persistent problem we've been discovering with some of the drugs, and I think the amputation team or the amputation team was working on that. I would love for them to create like a domain specific note about how to handle transplant drugs in this specific scenario. So we could get very specific, we get really broad. I think it's kind of a catch-all. What this is not is another discussion forum. So we have Jira, Slack, emails, issues, phone calls, whatever. We don't need another platform for discussion. So what the imagined use case I have for this is sort of the final resting place. After we hash out all the problems and figure out our solutions, this is where it would finally rest as it gets worked out. So as an example, there was a long email chain talking about vaccine data and how do we categorize and such. And then when Kristen put forward that email with a really nice description of how to use vaccine data in N3C, I went ahead and took that as the note, and that was kind of the final resting place for it. So that's kind of how I view this. Future versions of this, I'm hoping we'll be able to do some upvoting and downvoting as it hopefully builds up in the number of notes we have. I'd like some sort of quality control mechanisms in place. So as people find notes useful or valid notes, they could be upvoted. If there's some misinformation or improper information in the note, we could downvote it, and hopefully there'll be some sort of filtering by quality control through the community. We're also going to be adding more tags. So I would like to have, categorization by, use case level for new users. So I would like, novel user notes, intermediate level user notes, and then expert level user notes that would move up in, complexity and use case scenarios related to what stage you are as a user in N3C. And then I'm also working on a few usability improvements. So I have a beta version where I'm stitching together a bunch of notes. So instead of having just one single view of a note, we'd be able to put them together into one long document, and you can just read it as a nice flow through a series, through each of these, and they can be categorized and pieced together by tag or by whether it was a frequently asked question, etc. So I'm working on trying to design better usability for the dashboard. And then my final plea to this community, I would love it if each domain team could write at least one note answering one of the following prompts. So what is one piece of information or knowledge you wish you had at the beginning of working with N3C data? Or what is one challenge your team had working with N3C data that you either solved or have identified as a persistent issue? And then what do you think everyone should know or understand about working with N3C data? So if we get a couple domain teams respond to one of these prompts, that would be incredibly helpful. Even if you think it might be a replicate of a note that's already been put in, we can go back in and kind of clean some stuff up. We have some people, so I think the data liaisons, logic liaisons, and I think maybe myself are going to be working on trying to keep everything, keep some quality going. And then, final shout out to Amin from Palantir, who's really helped with designing, implementing this dashboard. And then also to the data liaisons and logic liaisons and other folks who have contributed some of these notes, and as well as giving feedback for usability and how to work forward, how to improve. So I can take any questions in the last 6 minutes here.
Hey, Tim, thank you so much. I think Anita asked a question. What is the review process to ensure that notes and FAQs are current?
Yeah, so because it's more of a community-driven approach, I think there's just going to be routine kind of curation or reviews going through. So that'll be me, and I think the data liaisons and logic liaisons. It's going to have to be a community-driven approach where if someone in the community realizes that one of the notes is out of date, either alert one of us and tell us it's either out of date, needs to be updated. We could. Oh, the other thing I didn't mention is you can add collaborating authors, and these can be edited and updated. So if something has changed and you are the author of a note, you can go in and you can go into that little menu I showed and edit your note. So you can update it. You can link and take away tags. The other thing is you can add collaborating authors who then will have edit access. So you'll only be able to edit notes that you created or you're a collaborating author on for those notes. So that is, it's going to be, I'm really hoping for a community-driven approach here.
Great, thank you. And Harold Lehman has a question. Should folks use community notes to advertise their knowledge store items?
I think so. The more places we can kind of link and point people, I think the easier it will be to find different items. And, with the knowledge store, it's really, you're trying to go through every, the titles and read through to figure out, which one is, which one of your knowledge store items is useful. Hopefully with the community notes, we'll have then tags associated with everything and all the links out and a nice brief description of what you're looking for. So hopefully it'll be a little more findable if you can use those as advertisements.
That was great. I think these were the only questions that we had.
It feels to me like there might be, like if you took them all together and just organized them, there might be sort of almost a living paper that you could publish in GitHub or something like this. Like it's, I think there's a lot of misperceptions about using real world data, and this collection is really exemplifies what all those misperceptions are and how to overcome them. So I think thinking in the future about how to disseminate this beyond our enclave environment would be a really terrific idea.
Yeah, I've kind of been toying around with that. As we collect more and more notes, it'll be interesting to see what people come up with and what actually ends up being the final repository. So yeah, I'd love to output that as like a cool paper or something.
Great, thank you. Thanks, Jerrod, Zach, and Tim for great presentations. One request, so would you be able to share your slides? I know you guys presented them from your own screens. So if I can get Jerrod, your slides as well as Tim, your slides, that'd be great, so I can distribute to the community. And if that's okay to distribute.
Yeah, happy to
Yeah.
share. I think we were both throwing them together kind of last minute here this afternoon. So sorry we didn't get them to you sooner.
No worries, no worries. Yeah, if you can share, then I'll send out a note by tomorrow to the community, and we want to keep them for our records as well.
Great.
Great, thanks everyone.
good.
We'll give 3 minutes back to the team.
Yeah, thanks for having us.
Thanks, everyone.
Thanks, everyone.